Friday in most intensive care units is always a special day. Most people see Friday as, woohoo, the weekend's here. We see Friday as, uh-oh, the weekend's here. Right now, our unit is full of very sick people. Let's look at the chart.
Okay.
We're trying to empty out intensive care so we have room for people who need it over the weekend.
There was an admission yesterday.
You can always feel the energy as the weekend approaches.
Out of the way, small.
We're in a good mood. That doesn't mean we don't take work seriously. And also, what's going to happen today? It's always interesting. I don't know why, but it's always something on a Friday. Something will be transferred or something will happen.
Doctors, like everyone, go home for the weekend, but they like to tie up loose ends so they can leave with a clear head. It's a day when sometimes you have to do a lot of things in a hurry.
Quite a few patients. Miss Laundry.
I'd like you to stop turning pages. You're starting to worry me.
But there's quite a few, like every Friday.
Here on Fridays, it's like everything must be sorted out. I need to sort out everything even more because I won't be here next week. It'll be a welcome break because I've worked 12 days in a row, so I'm really looking forward to when today ends. Hello. Today I'm in the emergency room. I'm going to have one patient after another. I try to prioritize them according to where they are in the emergency room. That way I have an idea of which patient is less stable and needs to be seen first. Hello, I'm Dr. Chagnon. They asked me to come to see you about your lungs. What happened?
My heart started pounding hard.
Oh, you had palpitations. Do you smoke?
Yes, a bit.
This lady has smoked for several years, and she has started to have respiratory problems.
I had a bad cough.
Since when?
For 2 weeks, I think.
I've looked at the x-rays of your lungs.
Yes?
Your left lung has completely caved in. The upper part is blocked. We need to go into your lungs with a camera to see what's blocking the bronchitis, okay?
Okay.
Since it's Friday and we don't want this to wait till tomorrow, I'd better call bronchoscopy to make sure they can get ready and schedule her exam for today. Thanks, bye.
How are the beds looking this weekend?
I'm not sure about the weekend yet.
Oh.
Michelle was...
Doing the math?
Yes, that's right.
Good. The weekend tends to bring us patients because there are a lot of people who, for personal reasons, can't miss work. On Thursdays and Fridays, because their illness needs treatment in hospital, they finally think, I definitely have to go. On the weekends, there are fewer active treatments. There are many surgeries where the potential complications don't happen on the day of the surgery. They happen in the following days.
He's fine. We're gonna discharge him. You know the other one well, I think.
I do. I'll go say hi. Is he intubated?
He isn't intubated.
I'm going to say hi to him in the emergency room.
Perfect.
The element of surprise is always in knowing if it's going to pick up. That often happens on Friday mornings because people tend to go out on Thursday nights. Hello, do you recognize me? You do, right? What happened? Tired, huh? Did you party hard yesterday? Not at all? You just didn't take your insulin. Although this is a patient I know well and expect to see on Friday mornings, I sit down and review the situation as if it were the first time. These patients have a right to come in with a different problem than what they always come to the hospital for. This time, for example, he might have pancreatitis, which he doesn't have usually. Maybe that's why he isn't feeling so good. It's important to be wary of routine. This isn't routine work. When we get comfortable in a routine, that's when we get taken by surprise and we might miss something. Hasty judgments are a trap. You have to be careful.
In our work schedules, we might be in the operating room or doing tasks outside the operating room. Perfect. Let's go have a word with them. The work I'm doing today is something we call being on the floor or doing post-operative. Being on the floor means being anywhere that isn't the operating room.
I'm just going to introduce you to the anesthesiologist who works with me, Dr. Fortier.
Good morning.
Dr. Fortier, nice to meet you.
Nice to meet you.
Thank you.
We'll start the day by going to see all the patients who've had surgery and need more advanced pain relief to tolerate the side effects of their surgery.
Your pain relief is still adequate. The last few days, your stomach was okay. Any pain?
No, there's no pain.
That's good.
The important thing is if you aren't in any pain, you'll be able to breathe better. Your general condition will improve. Our job is to help with that and make you as comfortable as possible. We'll come and see you again this afternoon to make sure everything's okay. She will really benefit from keeping the epidural in over the weekend. I don't want anyone to be tempted to stop it.
I'll put it on the report.
Thanks.
Thank you.
We have a day like this around every fortnight. We know when the day begins, that's going to be a hard day. We're a bit at the mercy of whatever happens in the hospital that requires our intervention.
In vascular surgery, the patients we see are usually the sickest in the hospital. These are patients who are very sick in all their blood vessels. When blood vessels are sick, every organ is sick. Hello. Today I have two cases. The biggest is an aortic aneurysm in a patient with one kidney. We'll cut from here to there, especially because you only have one kidney. The best way to preserve your remaining kidney is to protect it during treatment. It will be okay.
I trust you.
I'm on duty today. Something unexpected can happen at any time. When that happens, it can turn the whole day upside down. That's part of what we do. There's a patient who had a mini stroke yesterday, and he's having one again now. Don't bring the other patient in just yet. I want to assess him, okay? Yesterday evening, I got a call about a patient who had a mini stroke. His arm was paralyzed. He recovered. Usually, we don't operate right away. I thought, I'll go see him this morning. When I got to the 4th floor, the patient was not there.
This morning, he couldn't feel his arm. It was progressive. Afterwards, he had no feeling in his arm. So we sent him down to radiology for an emergency scan.
How long has it been?
A long time.
The neurologist and I looked at the scan. Basically, the patient's right arm is paralyzed again. Your carotid artery here is clogged. It sent up a clot. And that explains why you haven't regained use of your arm. It's very risky. But if I operate on you, there's a chance you'll regain use. If we want to do something for the patient, we'll have to do emergency surgery. So the day has just changed.
Hi. Today's Friday. This could be a big day for us, depending on when I have admissions. Sometimes a lot of patients want to spend the weekend at home. There's a kind of restlessness. Has it been fixed? My current position is assistant head nurse. Usually I'm a floor nurse. The regular assistant is on vacation for 3 weeks, so I'm filling in. Yes, hello. This is the assistant. I don't take vital signs, I don't administer medicine, but I know the patients by heart. Every patient. All 32 of them are my patients.
Hello, 10AB, hello?
Nadej, do you have an admission in 18? On the 10th floor, we're a very busy unit. We get patients from the emergency room or the coronary unit, leaving aside the fact we're often over capacity, and there are patients we put in the corridors. Sophie, just to let you know there's an admission in 15. We'll take them soon. The aim is to unclog the emergency room as much as possible.
Hello, I'm Dr. Chagnon. I'm a pulmonologist. They asked me to come see you because you were having respiratory problems.
Yes.
Do you have asthma?
Yes,
Since when?
for a long time.
Asthma is still a severe illness. If it gets worse over a long time and the problem isn't addressed, you can even die from an asthma attack. But right now, I'm not worried for her life. We're going to stop the salute. We'll give you antibiotics orally. You'll feel better in the next few days, then you can leave.
Well, the next few days, I have to leave by tomorrow because my daughter's all by herself at home.
All by herself?
Her grandma's there, but she won't be there tomorrow.
Can't your husband take tomorrow off?
He can't. He's taken too much leave. He'll get fired.
But you're not well.
Well, I don't have a choice. I need to be there for my daughter.
It's a shame. When children are involved, that can make us even more sensitive or empathetic.
I'm here, but my mind is at home. It's nothing but stress.
I understand. But her treatment will be incomplete. She may have to come back to hospital again because she may not be able to get through this current episode optimally. You came here because you were having trouble breathing.
Exactly.
Now you're feeling better?
Not bad.
Okay, the nurse was even telling me you wanted to leave.
Yes, ma'am.
Because look, that's your oxygen level.
I know it isn't.
It isn't high.
I know. But I'm ready to leave. Rent an oxygen concentrator.
You can't rent one on a Friday afternoon.
Because I can't. He's going to drive me crazy, that nutcase. That lunatic is going to drive me crazy.
Maybe we can ask to move you somewhere else to another stretcher.
He's yelling. He's been yelling for 17 hours. I can't bear it. I need to go home and sleep.
You might get arrhythmia here. Your heart rate could shoot up.
Are you saying I have to stay here?
It could put your life at risk. If you leave, I'll have to make you sign a document
I'll sign it.
saying you're leaving against my advice.
I'll come back if you want.
Well, I'll have you go to an external clinic, but it won't be tomorrow. It's not ideal.
This isn't a joke. I'm not joking. But I can't stay here for a week. He's going to drive me crazy.
Breathe through your mouth. Normally, I would keep her in hospital because her oxygen is low. I don't have the criteria to send her home safely. Breathe. We try to improve patients' conditions, but she has decided to leave without completing her treatment. She's going to sign a document to say she's leaving against her medical advice. However, I'm going to write her prescriptions. Maybe the fact that it's Friday has hastened her desire to leave, but she might have complications from a lack of oxygen, or she might not take her medication properly, because we haven't necessarily taught her how to do her therapy, inhale, and everything. There's a risk she'll need to come back to hospital.
Hello. How are you?
It hurts.
Where does it hurt, Mr. Fournier?
My back. 10 out of 10.
In post-operative pain management, the implication is that we're going to manage pain. There's value in meeting the patient, talking to them, and reassuring them. There's also value in some cases in using medication that can help patients, among other things, to control their anxiety.
When you push the button, does it give you relief?
It hurts at first.
Okay, but how's the pain after?
It gets better after. Tonight it took a long time because it was recent.
Exactly. That's what I was going to say. The worst time is the first few hours after treatment begins. That's the worst. That's why we've given you a machine that lets you give yourself pain relief. Pain is like a forest fire. It's easier to extinguish 2 trees than half the forest. See what I'm saying? Excellent. The challenge of a new treatment, of a new medicine, is that we want the patient to work with us. For them to work with us, they can't be out of it. We can't blunt a patient so that they don't know what's going on. On the contrary, we want patients to be able to have a say in their care. We try to speak to them and listen to them.
How are you, Miss Laundry?
Fine. I'd be better if it wasn't so hot. It's so hot in here. It doesn't look good.
Try not to get up if your legs feel weak. I wouldn't want you to have an accident.
I know my legs are weak.
Okay, ask for help.
Before, if my legs were strong, I would have walked over there.
Yes, I know.
But I'm not dumb enough to fall flat on my face.
How is the pain?
Oh, the pain. It doesn't hurt anywhere. I'm eager to leave.
Okay. An anesthesiologist's role is a bit misunderstood. People always think that we're in the shadows, outside the process of communicating with the patient. On the contrary, people who do anesthesiology have strong interpersonal skills. We'll keep an eye on you because we don't want you running in the corridors. It's against the rules.
Yes, I know that in hospitals you shouldn't run in corridors.
Get well soon.
Oh, I'm fine.
That's what we thought.
Dr. Prano, do you want me to get out the prescriptions if you have any departures?
Yes, please.
Okay, I'll get them for you. They're taking him to the dermatologist now. The doctor I'm working with today is Dr. Nicholas Prano. He's the cardiologist on this floor. He's coming to the end of a 2-week rotation. He's going to visit his patients, and he might discharge a lot of them today.
1004, Mr. L, discharged.
Okay.
Mr. M, in 5, have requested a PICC line for his antibiotics. It's Friday.
Ah, a PICC line. So is it urgent? A PICC line is a central venous catheter. PICC lines are complicated on Fridays because they're done in angiography, which we don't have on weekends. If there's no PICC line, it delays the discharge by 3 days, as they need a PICC line to get antibiotics at home.
We'll let the gentleman in 4 go home.
Okay. When you're discharged, it's official. I sign it off. As soon as I sign it off, sometimes within a few seconds, I already have the name of someone who's going to take their place. Where is Mr. Saint-Germain?
I don't know. Gone.
I wanted to check if you had managed to arrange transport, because you need to leave the room. Other patients are coming.
All I have to do is call.
Okay, you should call because...
Do you have my papers?
It's all done, all signed. The nurse...
Can I get dressed?
Get dressed.
But they have to take off my cast. Send me the nurse.
I'll send the nurse. Are you going to wait in the waiting room?
Yeah, okay, fine.
Okay, no problem. This patient is known since this morning he was being discharged, but he's still in his room. It's a bit uncomfortable to say we're making you leave because we have to take in someone else, but it's urgent. The other patient is waiting. Yes, hello. This is AB on 10. I have 2 patients who are coming up to us. Can you send me the reports? We try to help as many people as we can.
I have a small emergency. It's going to take around an hour and a half. After that, I'll be with you. On Saturdays, there aren't 8 operating rooms. There's 1, and it's for emergencies. So if emergencies arrive, you can't say, I'll do it tomorrow. You have to deal with it now. The logistics of treating patients gets complicated. You have to know what to do, when, and in what order.
We have an urgent case here, Mr. Nault.
Mr. No had a mini stroke yesterday, which he recovered from. At 1 a.m., he was fine. At 6 a.m., his arm was paralyzed and he had dysarthria. If we want to restore function, this is his only chance. He has a 10 to 15% risk of a stroke, 5 to 10% of death. Even so, we talked to him, we explained the risks. He wants surgery. However, if something happens, he doesn't want us to revive him. That is to say, if we can cure his paralysis, we'll do it. But if he dies, we won't do anything. Should we go, doctor? Let's go. Go. When you open the carotid artery, you have to put clamps on both sides to stop circulation. For this morning's patient, if we didn't restore his blood during the operation, for the 20 or 25 minutes during which he didn't have circulation, I think he would have had serious brain damage. Shall we go? Clamp the internal one first. Just by stopping circulation, we saw the oxygen to the left side of his brain decrease enormously.
It's really dropped.
Yes, it's fallen. So the challenge was to get circulation flowing again as quickly as possible. Flyers, please. When we operate on the carotid artery of someone who's very fragile and their brain isn't getting enough oxygen, we put in a shunt. A shunt is basically a tube through which blood passes from one end of the carotid artery to the other while we work. It's a key moment of the operation. Time for the shunt?
1 minute, 5 seconds.
Thanks. The anesthetist uses his equipment to look at the oxygen that's going to the brain. And we work together to find out if we should raise the pressure or whether the shunt is working or not. It's gone up to better than it was.
Yes, it's going up.
Is it rising?
Yes.
Okay. The shunt is working well. Perfect. At every point of the operation, I keep an eye on the anesthetist equipment. And the anesthetist watches me to see where I am and what I'm doing. So it's really about teamwork. With the nurses, with the anesthetist, the interns, everyone. Yes! Good, thanks.
Hi?
Yes, Anik? Could you ask for the next patient, please? The aorta.
Yes, sure. The aortic aneurysm?
Exactly.
Perfect.
Thank you.
The intensive care unit at Maisonneuve-Rosemont is a small unit compared to our population. Often we go from the level of full to overflowing. Right now we're full. Really full. Hello. I'm Dr. Marquis from intensive care. Your doctors asked me to come and see you because it's getting hard for you to breathe. Is that right? Yes, looks like it, doesn't it? When did this start?
Over a week ago.
Over a week ago. Okay, let's listen to your lungs. She looks fine. She's smiling and talking. She doesn't look unwell. But there's enormous potential for her to become unwell. Her treatment team told me she sat up for the last 2 nights. She can't lie down on the bed. She's going to wear herself out. Her respiratory condition will get weaker and weaker. This is a typical Friday appointment, because if I looked at the direction she's heading in, I'd say that by Sunday afternoon, she'll be very unwell. Yes, this is Francois. How many beds do we have available for someone who isn't on the verge of death, but who really needs our help? It's full, okay. But as I said, it can wait until our next discharge. It just means we'll have to amp up our treatment. I have 1 bed left in intensive care for the entire hospital. If I put someone in it right now, and then there's a heart attack in 15 minutes, I'll be in real trouble. When a second bed becomes available, we'll keep our backup bed and put the patient in the next bed.
Hi, Marianne. How are you?
Still not good.
Yes?
This patient had major orthopedic surgery. In some cases, this leads to pain called neuropathic pain. It feels a bit like an electric shock. It's chronic and very psychologically demanding. How do you feel compared to yesterday?
What was yesterday?
You were in pain.
You were in pain.
It calls for a specific class of medication which alters the sensorium. Patients get a little confused. We found a way to make you better, but what we want now is to give you more control so you feel okay. You don't have to sleep if you don't want to, but if you want to sleep a bit more, you'll be able to treat yourself.
Why don't you, let's decrease the dose. You'll start from 10 millimeters an hour and go down to 8 millimeters an hour. You're going away for the weekend and I'm here suffering.
What's notable about Fridays is that we have patients who realize their doctors won't be at the hospital for 2 days. There's a kind of anxiety that they might not receive the care they need. We understand your concern because the weekend is approaching and you're scared people won't be there to look after you. But because you're with the post-operative pain management service, someone will come and see you every day on Saturday or on Sunday.
We'll keep adjusting and making you comfortable, okay?
We've seen that something is blocking your bronchus. I'm under the impression that it's a tumor. It could be lung cancer. As I said, I think it's cancer, but we have to prove it. But that's what it looks like. The problem is, it's the weekend. You're probably going to have other exams next week. I think she was surprised, both her and her daughter. They weren't necessarily expecting that, but with bad news, I think you have to take time to give information. You also have to ensure the patient has understood most of the information you've given them. Because sometimes when we deliver bad news, I think patients can't take it all in because their emotions come into play.
That's right. I've smoked all my life, and I can't live without it. I knew that one day I'd pay for it, but
No matter your illness, if you stop smoking, you'll live longer than if you keep smoking. I'm going to prescribe you patches so it isn't so difficult.
okay.
The table broke.
What happened?
The bed hooked the button, then it ripped off, and now the table isn't responding.
When there's a problem in the room, right now the table isn't working. It's in the patient's best interest for everyone to find a solution so we can operate as quickly as possible. Everyone comes together to solve little problems. That's right.
Whether you plug it into the back or the front,
On days like today, where everything starts off fine and suddenly it all changes, you have to stay calm. It's Friday, you say. Let's take it one step at a time and deal with the changes however we can. Aha! As a last resort, we would have gone to another room. In this case, we're able to find a solution together. Yes, you can open it in mass. More. Scalpel to the skin. The aorta is an organ that, even if we go through the front to get it, it is stuck next to the column behind. When we go through the front, we have to compress all the intestines. If we make a hole in the artery, I'm trained for it, right? If I make a hole in the intestine, then I have to call someone. And it's Friday. During training, we explain to residents, you're better off sticking with the things you can fix than being forced to call a consultant on a Friday. I don't think he wants to come and do surgery on a Friday afternoon or evening on a case that's suddenly much more complicated. All right, let's cap it. Does anyone need to pee? Because there's still time.
If I asked all my colleagues in the operating room today if they wanted to trade places with me, generally speaking, they wouldn't, because today has been going against my desire as an anesthesiologist to control the environment. It's a bit like being the operating room manager, someone who makes sure everything's working properly. When you're on the floor, you can't control that.
the machine has never done that before.
It won't stop in the next few minutes. There's plenty left. You aren't in danger.
Thank you.
It's all good. In general, this is nobody's favorite day. It's a day full of surprises, where we get a lot of calls. Yes? It's Dr. Fortier in anesthesia. We could get called at any moment by obstetrics on the 7th floor to come and do an epidural. Perfect. No problem. I'm on my way.
Bernard, you have 16? He gave me the report this morning. He doesn't want compo with his medicine anymore. 16-2. Yes, hello? 10 EAB? Sometimes I answer the phone at home. 10 EAB, how can I help you? I'm calling to see if I can get a PICC line today. It was requested a while ago. When we have a big day, our team says, oh my God, it's like Friday. Because on Fridays, we work a lot more than on other days of the week. I know it's Friday, but it's hard right now. Discharge here. Gentleman is leaving. Things are on the move. I said room 18 was being emptied. She started in 17. When things are moving, everyone wants files and appointments. Then the consultants start coming in to check the files too. This is an overflow case, 81-year-old, 3273, so he needs a monitor. I'm very calm by nature. I can listen to several people at the same time and respond to each of them. Through the noise, the phone, the carts going past, the bells ringing, I can stay focused on the priorities, really going according to the priorities. We become super vigilant because if we forget something, it's a lot of weight on our shoulders. These are people's lives.
Hello? We have a patient who's here in an in utero delivery.
Yes,
Okay. How's the patient?
she's fine.
Okay. How long has she known?
A few days.
Okay. Good. We were told that this was a patient who needed an epidural at 30 weeks of pregnancy. The epidural is for fetal extrusion, not at birth. It's very different. It's a particular situation where a fetus is still viable, but the potential quality of life is extremely, extremely poor. I'm Dr. Fortier, the anesthesiologist. I've come to give you an epidural to relieve your pain. I have a few questions to ask you. Are you having a contraction? Let it pass and then I'll ask my questions. It's a sad situation. There's no trick for these situations. I try to understand how the mother might be feeling, but there's no point imagining it because often we come to the room and her way of interacting with us tells us where she is in her thought process. Okay, that's the worst of it.
You're pretty good.
Yes. The mother we did the epidural on had already had some time to grieve. She was sad, but at the same time, she wasn't despondent or angry either. She was quite composed. My pleasure. We're here for you. On a day like today, there can be events that make you think, well, it's sad, it's moving. We can feel it getting to us, but at the same time, we have to get back to it and finish the day. Sometimes we get home and feel it more strongly and experience emotions from 5 hours ago. That can happen.
We'll send the patient down.
Okay.
She wants a no code, so we can't make any mistakes.
Cette patiente-là a manifesté.
This patient stated that she didn't want CPR.
Cardio-respiratoire.
Since she doesn't want CPR, there are people who'd think it's much easier. I mean, worst case scenario, if she has a heart attack, it's over. But from my point of view, it's more difficult because I'm used to resuscitating patients. Hello again. I have fewer possible options. I have less room for maneuver and fewer tools at my disposal. I've had my options taken away. This is someone we need to be twice as careful with because we don't have a backup plan. This is the kind of patient who could easily go from a stable condition to a very unstable one. I'm going to arrange her echocardiogram because it's Friday. Tick-tock. In your to-do list, an echocardiogram for a metal mitral valve. I need it today because it's a bit pulled out and her valve isn't singing how it should.
Okay.
Excellent. Thanks a lot. As intensive care doctors, when we walk down the halls and meet people, families, we have to take advantage of just about every moment we get. I don't want an immediate answer. I'll see you tomorrow and over the weekend. We'll see what direction it takes. But these are questions to think about before anything goes wrong, okay? What I said to this patient's daughter was, look, your mom is calm. She's fine. I know she's left a do not resuscitate order. And we know she's here for a respiratory condition. Before her heart stops, there's a chance she'll have a respiratory problem that will require intubation and a ventilator. And that's not covered by her order. So I took advantage of that. Talk it over gently with her. Talk it over gently with your father. Get your head around it and we'll talk tomorrow, okay? I just don't want to do something she'll regret later. I talked about the pros and the cons. I gave just enough information for them to discuss. Tomorrow, I'll answer their questions. Then, if they're ready and they've made a decision, we'll adjust the level of care as a result. We'll also be able to see, after 24 hours of treatment, which direction it's going in.
Mr. Oji?
Yes?
Hello.
Hello.
I'm Dr. Chagnon. I'm a pulmonologist.
All right.
The patient was transferred to the cardiology institution because he had chest pain initially. They did a chest scan and they saw he probably had lung cancer with metastasis. Do you have a lump that's gotten bigger?
Yeah, and there's another one coming.
The pulmonologist there decided the patient needed to be hospitalized for tests, so he asked to transfer me here to Maisonneuve. In the scan, it looks like there's a tumor on your lung.
Okay.
On your left lung, it looks like cancer. It would be in the fairly advanced stages.
Right, yeah.
It seems to me that the cancer is progressing quickly and it could be life-threatening. So it's definitely important to observe him at least over the next few days. He's at risk of deteriorating rapidly. I'm not sure he could tolerate the delays for external tests. You don't want to stay?
Well, what can you do? If there are reduced staff on weekends,
Of course, the test will be a little faster if you're in hospital.
I don't want to hang around for 6 months, 1 year, 2 years. I'd rather say, okay, if I have 6 months left, I'm going to live my 6 months. Do you understand?
You mean you don't want to waste time here with me? I understand.
No, you're nice, but...
No, I understand very well.
So at the first exam on Tuesday, they can get a good
idea. We'll probably get the results on Wednesday, Thursday at the latest.
I'll be here until Wednesday?
You'll stay here.
Is that clear?
Do you want to go back to your bed? I'll call an orderly. An orderly needed at the station, please? We don't just treat the person. We treat the person in their situation with their family. We have to respond to the family's needs, particularly with this patient because she has 2 young children, a girl and a boy, and they lost their father a few years ago. It's only the mother left, and the mother will be in palliative care soon. The boy's worried. He said, "I'd like to see the doctor because my mother is in pain. Her hand is very red."
I'll go and look at the evaluation now.
Okay. We're very sensitive to people's distress. He comes every day. He visits his mom every day, and he can see the progress of her disease. We don't want him to worry. Did you see Miss Rayom this morning? I called the doctor right away to see to her needs and reassure her.
I thought Ms. Rayom was doing quite well.
She was sitting here and she was all red and moaning. I asked her if she was okay. She said, no, I'm in pain.
Okay.
It's important to us that the patients and their families are happy with the care they're receiving in hospital.
I'll prescribe something for her pain as needed. I'll call her children to reassure them. I think she's fine.
They need reassurance. They're young, after all.
All right. I'll call them. Thank you.
I think we're done here. I'm going back to the OR, okay? Have a nice evening.
Have a good weekend.
We're off to the OR. Days outside the OR are very heavy going. Physically, when the day's over, you're worn out. But more than that, when you're on second call, when your shift on the floor is over, you go back to the operating room and you have to start helping to close the rooms. The chart is wrong today.
Really?
I'm having trouble here. Supposedly Dr. Tanobi was in 15, but 15 is empty. Bruno, do you have any idea?
What?
Sam was supposed to be in 15. 15 is empty. I'm the operating room coordinator. One of the things I do during the day is make sure I know where the troops are and who's doing what in the rooms. I wasn't there. Where's Hussein?
I don't know.
So when we got there, it kind of illustrated how someone needs to oversee everything to make sure the information is correct.
Sophie is in 4. You have someone in 5.
Dr. Tanubi should be in 14.
14?
Yes.
I've come to replace you. We'll meet in the next room to finish, then we can do it in sequence. There are some days when we do 3, 4, 5 room changes. Dr. Robert, how are you?
Big day?
Very. The end of the day demands a lot of concentration, but you have to transfer patients, and sometimes they're complex cases. We have 15 minutes to adapt and do emergence, which is one of the main stages of anesthesia.
When we get to the end of Friday, the activities in the hospital slow down significantly. That means there's really a race to set everything up before that moment comes. But didn't you do a direct consultation?
That's what he had to do. I don't know if I didn't do it.
Okay, I think I'm going to see him. I'm going to ask him some questions.
You're better off knowing on a Friday. The sooner the better.
No, I'm going to take a look at the patient. The patient could be checkmated in 3 days. Let's go. Let's go and see him. Hello. I'm just going to look at the scan with you while you do it. That will give me an idea if suddenly he'll need my services tonight. We use all the information we have. That's why I wanted to go and see how the scan was going, because that gives me an idea of how the next days will go. As an added bonus, I have the images from the scan. I especially wanted reassurance when it came to his breathing that he didn't have pneumonia. Sometimes when someone's immune system has been compromised, pneumonia can develop without the patient being very symptomatic. Okay, it's all right. I'm going back. Thanks a lot.
Thanks. My pleasure. Bye.
Bye. In the images from the scan, I can see there's no disastrous infection. All in all, it's reassuring enough for me to think, this patient doesn't need intensive care right away. And if needed, we'll come see him again. Upstairs, I went to see a hematology patient. He's doing well. The scan is all right. He doesn't have anything major wrong with his lungs. All right, thanks. Fridays are often interesting days because they're exciting. Because we feel like we're giving it our all. But you get tired when you've given 110%.
The more you cut, the more likely it is to bleed, right? How long? Once we've stopped the bleeding above and below, we connect the aorta, the heart, and a piece of synthetic fabric with thread. Plumbing and tailoring. That's what we do. All right? We're happy. Done. Once everything is connected, we inform the anesthesiologist, because when we remove the clamp that's stopping circulation, blood is going to flow to the patient's legs. That can cause something called hypotension, and that's where teamwork with the anesthesiologist becomes important. Unclamp. Okay, that was fun. When let's say, the more stressful part is done, everyone goes, oh, okay, that went well. Let's carry on with the rest. It's familiar, it's gonna be fine, because it usually is.
Right, A.R. Twiliak?
Yes.
We've lost 1,300.
At the end of the operation, I let a resident close the abdominal lining. At that time, I check the patient's feet to make sure blood is flowing properly. That allows me to check before everything's closed up that what we did is working.
End of case. Merci.
Thanks, everyone.
Thank you.
Bye.
Bye.
He didn't lose too much blood in his kidney. It went well.
Good.
We'll see how he is when he wakes up. We won't count our chickens.
Is he going to a room or intensive care?
Intensive care for at least 48 hours, I would think.
Okay, all right.
Okay. I'll come back and see you soon when he wakes up.
Okay, thank you so much.
My pleasure.
Have a nice day.
An orderly needed at the station? It's not like when you work in a supermarket and Friday it's finished. We can't leave until the team has come back. We can't leave if everything isn't sorted out with the patients. It's fine. I'm done. I'm on vacation, a week-long vacation, and I'm not working on the weekend. It's going to be a long break. I don't know what I'm going to do.
Have a nice weekend, Layla. Have a good rest.
Thanks. I'm on vacation.
Oh, yeah? Well deserved.
Definitely.
Merci.
Thank you.
It's my pleasure.
Have a good evening, everyone.
Have a good weekend.
At the end of the week, today in particular, with the way it unfolded, it's pretty satisfying. I really feel like I've made a difference on a small scale with a lot of patients.
At the end of the day, we're going to visit the patient we operated on this morning. Now he can talk again. How are you?
I'm fine.
Are you fine? Oh, yes, it's starting, isn't it? He's beginning to move his arms. It's a start. We never know if our treatment has really changed the future, but right now, I think it has. It's coming. You just have to be patient. That's good. Back to the recovery room to check the last case. How are you? Are you in pain at all?
No.
No? You're good? Your surgery went very well, okay? With my second elective patient, who I couldn't treat, I explained there was an emergency and he was very understanding. I told him, you'll be the first one at 8 a.m. on Monday morning. It was a good day. It was a typical Friday here. A few surprises, solving problems on the fly. Like one of my friends, who's a pilot, says, if you've landed the plane and everyone is fine, it's a great day.